The first test we're going to do is the Janssen test. We're going to have the patient seated. We're going to have them bring their right ankle up to their left knee, just like that. A positive test is if the patient is unable to perform the figure 4 motion or if there's extreme pain with it. This test indicates OA changes in the hip, may also indicate a decrease in flexibility in the hamstrings, glute max, or multifidi. Patient may also compensate by putting their arms behind to get in a little bit more of a relaxed position and perform this test as well. The next test we're going to do is the sign of the buttocks test. What we're going to do is have the patient lying supine. This test is done completely passive. So at first I'm going to bring the leg up in a straight leg raise. We're checking for range of motion and end field. The end field on this is, on the straight leg, is most likely going to be a spasm or a capsular, and it's definitely going to be painful. The next thing we're going to do is return them to neutral and move them passively in hip flexion and knee flexion at the same time. Again, checking for range of motion and end field. If there's no change in the range of motion, the pathology is within the hip or the buttock and not the hamstrings or sciatic nerve. And also in the second part with the hip and knee flexed, where there's most likely going to be an empty infield and it's going to be more painful than the first part with the straight leg. To be positive, restrictions in the straight leg must be congruent with the limited hip flexion and a non-capsular pattern of restriction in the hip range of motion. The next test we're going to do is the abductor contracture test. What we're going to do is have the patient laying supine. First, the therapist is going to check the levels of the ASIS and make sure they're level. Then I'm going to bring the leg out into abduction here. And when I move it back into neutral, the affected side, so this ASIS is going to be shifted up, and that would be a positive sign for adductor contracture. For abduction contracture, we're going to do the same thing. We're going to check the ASIS, make sure those are level, and I'm going to move them into slight abduction. And when I pull them back into neutral, the ASIS will drop, and that would be a positive sign for an abductor contracture. For Faber's test, what we're going to do is have the patient lying supine. This test is done passively, so I'm going to passively move the hip into flexion and external rotation as I place her ankle onto her opposite knee. Then I'm going to have, I'm going to assess the range of motion, and if she doesn't have full external rotation in her hip, that would be a positive sign for type hip flexors. And then the second part of the test, I'm going to have one hand placed over the ASIS, the other on her knee, and going to apply pressure downward. If she has an anterior pain in the testing hip, that would be a positive sign for anterior capsule pain. The next test we're going to do is called the Fader's test. We're going to have the patient lying supine. I'm going to passively move the patient into hip flexion, adduction, and internal rotation. If there's pain with pressure, that would be a positive test. If there's pain in the posterior lateral aspect, that would be caused by a stretch. And if there's pain in the medial or anterior structures, that would be due to compression. The next test we're going to do is the Craig test. What we're going to do is have the patient lying prone. We're going to move them into 90 degrees of knee flexion. Then we're going to palpate over the greater trochanter. We're going to move them into external and internal rotation. And we're checking to see when the greater trochanter is at its most lateral point. And once we find that measurement, we're going to hold them in that position. And we are going to check the degrees. We're going to have the fulcrum over the anterior aspect of the patella. The stationary arm is going to be perpendicular to the table, and the moving arm is going to be up the leg. We're going to take that measurement. If they're in internal rotation, average males is 35 degrees, and average females is 45. And if we're in external rotation, the average degrees for both males and females are 45 degrees. And if they had any deviations on that, that would be a positive sign for either anterior anti-version or retroversion of the hip. The next test we're going to do is called the modified Thomas test. What we're going to have the patient do is stand next to the table. I'm going to have them go ahead and grab their knee in a hip flexion and then slowly lay back onto the table, just like that. From here, we're going to check the level of the leg she's not holding, so her opposite leg. And then I'm going to move her into knee extension and going to drop. What we're checking for is to see is if there is a drop when there's a leg extension, then we know that there is a tight rectus. And if when we extend it and there's no change of position, that would be indicative of a tight iliopsoas. We can also do this test in an abducted position. And when you do it in an abducted position, it's the same, you're looking for all the same things, but what we're doing when we put it in abducted is we're eliminating the possibility of a tight sartorius and a tight TFL. And so this test would be more specific to rule in a tight rectus. The next test we're going to do is called the rectus femoris test. It's like the Thomas test, so we're going to have the patient be standing next to the table here. I'm going to have them go ahead and grab their knee and lean back into the table, just like that. And then what I'm going to have the patient do is actively flex their opposite leg. And we're going to take a measurement here, so we're going to have the fulcrum over the medial condyle of the femur. Then we're going to have the stationary arm up the femur, and then the moving arm is going to be down pointed towards the medial malleolus, and we're going to take that measurement. The normal range of motions would be for a female is about 112 degrees, and for a male it's about 105, and if they had anything less than that, those degrees, it would be a positive sign for a tight rectus. The next test we're going to do is called the Ober's test. What we're going to do is have the patient lying on their side here. I'm going to be standing behind them, making sure that I'm supporting them so they don't feel like they're going to roll off the table. I'm going to have one arm over the hip to make sure that it stays in place. I'm going to take the other arm and grab the patient's leg. What I'm going to do is move them into hip flexion, abduction, and roll it over. And I'm going to apply pressure down on the hip as I slowly let go and measure. And if the patient is below parallel with the table, like she is now, that would be a negative sign for tightness in the IT band and tensor fasciae lata. And if her leg was above parallel, that would be a positive sign of those two tightness. We could also move into the modified Ober's test, which is the same test except we have the knee bent now. All the same procedures, except now we are eliminating the IT band, so we're only focusing on the tightness of the TFL. Okay, so the next test we're going to do is the piriformis test. We're going to have the patient lying supine here. I'm going to take their leg and move them into slight hip flexion. We want to make sure we're not going over 90 degrees. And from here, I'm going to just cross over and apply pressure. And if the patient has pain in the posterior buttock over the piriformis, it would be indicative of a tight piriformis. And if there's radiating pain down the leg, we should also be cautious and check the sciatic nerve because it does run through the piriformis and it could be slightly impinged. Next test we're going to do is called the Scour test. What we're going to have the patient do is just be laying supine. I'm going to move her up into hip flexion, about here, and I'm going to apply an axial load, so I'm going to be pushing down on the knee, and while I do this, either in an abducted or adducted position, you apply the pressure down, and then you externally and internally rotate the leg, and if there's any pain with that test, that could be a positive sign for OA or a labral tear. If there's any clicking, things like that, it's usually for a labral tear. And also during this test, because we are applying an axial load, the patient may complain about pain in the mid buttock region, and if that's true, that may be a positive sign for SI problems. The next test we're going to do is the log roll test. We're going to have the patient lying supine, and I'm going to passively move the leg into maximal external and internal rotation, just like that. Eliciting clicking or popping sensation may be indicative of a acetabular tear. And if there's an increase in range of motion compared to the non-involved side, that may be a positive test for ligament or capsular laxity. Okay, for the Ottawa knee rules, first thing is if the patient can take 4 steps. The next rule is if they can get to 90 degrees of flexion, so you can have them sit. So 90 degrees of knee flexion. The next rule is if they are over the age of 50 and if they have point tenderness over the patella or the proximal head of the fibula. If they have, if they can't perform any of these, or if they have point tenderness and over the age of 50, for any of these rules, they would have to be sent in for an X-ray. So the first test we're going to do is be checking for effusion. There's 2 different tests that we can do. The first test is the milking test. What we're going to do is basically just gently stroke upward on the medial aspect of the patella. And what we're trying to do is push the fluid to the top and out of this region. And then once we do that a few times, we're going to push on the lateral aspect of the patella. And if that happens, there should be small effusion when the fluid is coming back in onto the medial side, and that would be a positive test. The next test we could do is the ballottement test, and we'll have the knee slightly flexed, and we're going to be basically pushing the skin together over the patella, trying to move all the fluids into the knee joint. And then we will gently push down on the patella. A positive test here is if there's sizable effusion over the patella, and the patella will feel like it's floating and bounce when it's pushed back, or when you push down on it. And that would also be a positive test for effusion. So the next test we're going to do is the patellar quadrant test. We're going to have the patient lying supine. I'm going to grasp the patella here, and I'm going to push it into the medial direction and the lateral direction and up and down. And we can also go in the diagonal directions. We're basically just checking for patellar mobility. If there's any hypomobility, so if the patella is only moving about less than 1 quadrant over, that would be a positive sign for hypomobility in the patella. And if it moves over more than 3 quadrants, that would be hypermobility. And we can also do a little bit of a patellar tilt and check the tilts and make sure that there's no pain in any of these tests. And if there is pain, that would be a positive sign for a patellar pathology. So the next test we're going to do is called the SAG test. We're going to have the patient lying in supine. I'm going to passively move them up into 90 degrees of hip flexion and 90 degrees of knee flexion. We're going to be holding here down by the ankle. What we're looking for is a sag over the joint line here. And if we run our finger across, we may also be able to feel a step up. So those are both positive signs for a tear in the PCL. So the next test we're going to do, the posterior drawer test and the anterior drawer test. We're going to have the patient lying supine. We're going to move their leg up to about 60 degrees of flexion, and then we can go ahead and place our thigh over their leg just to keep it stable. I'm going to be palpating with my thumbs over the joint line, and I'm going to be grasping the tibia. And what we're going to do for the anterior drawer is apply an anterior force. And then for the posterior drawer, we're going to be applying a posterior force. And what we're looking for is any hypermobility. So in the anterior drawer, we're pulling forward. If there's pain or hypermobility, that would be a positive sign for a tear in the ACL. And if we're pushing backwards for the posterior drawer test, and if there's any pain or hypermobility there, that would be a positive sign for a PCL tear. So the next test we're going to do is the Lachman's test. We're going to have the patient lying supine. I'm going to go ahead and put my leg up on the table just to get the leg in a little bit of a flexion here. You're going to have one hand up on the thigh, and the other hand is going to be down here on the tibia. We're going to make sure that our thumb is palpating over the tibial tuberosity. We want to make sure that we get a pretty good grip here. And this top hand here on the thigh is just going to be used for stability. And the bottom hand here over the tibia is going to be applying an anterior force. Just like that. And what we're doing is checking for any pain or hypermobility, and that would be a positive test for a tear in the ACL. Okay, so the next test we're going to do is the valgus stress test. We're going to have the patient lying supine. At first, we're going to do the test at 0 degrees of flexion, so we're going to be here. And we're going to apply a valgus force to the knee. And what we're checking for is any pain in the medial side or hypermobility. That would be a positive sign for either a tear in the MCL, MOL, the ACL, or the PCL. And then if there's pain on the lateral side, we may be thinking more of a fracture, and we might want to send them in for an x-ray. The next thing that we're going to do is go ahead and test it at 30 degrees of flexion. So I'm going to put them at 30 degrees of flexion, do the same test, and that's more indicative of just a tear in the MCL. So this next test we're going to do is the Veris stress test. We're going to have the patient lying supine here. We're going to first do the test in 0 degrees of flexion, and we're going to go ahead and apply a Veris force like that. And what we're looking for is any pain or hypermobility on the lateral side of the knee, and that would be indicative of the LCL, the ACL, or the PCL. And then we're going to redo the test at about 30 degrees of flexion, do the same thing, and apply a Veris force. And that is just going to be more indicative of the LCL. The next test we're going to do is the Apley's distraction test. We're going to have the patient lying prone. I'm going to bring the leg up into about 90 degrees of flexion, and I'm going to be applying a distractive force. So I'm going to be lifting up here on the leg, and then I'm going to apply an external and internal forces. When I am applying an external force, we're going to be provocating the MCL, and I'm doing an internal force, we're going to be provocating the LCL. And a positive test is if there's any pain during those motions, either externally or internally rotated, or hypermobility. While doing the Apley's distraction test, we can also apply the DDV maneuver. So we're going to be lifting up, and while we're externally rotated, we can go all the way through the range of motions, and go internally rotated as well, and go all through the motions, just to see if we can provocate those ligaments anymore. Is the Apley's compression test. We're going to have the patient lying prone. We want to make sure that we have a towel up under the distal portion of the thigh. We're going to move them into 90 degrees of flexion, and we're going to go ahead and apply a axial load. So we're going to compress down on the knee. We're going to move them into external and internal rotation, and we're going to ask where the pain is. The pain's on the medial side, it's most likely a medial meniscal tear. If it's on the lateral side, it's going to be more of a lateral meniscal tear. And we can also combine this with the DVT maneuver. So we're going to be applying down in external rotation, provocating it all the way through the range of motion, and we can go with internal rotation and do the same thing all the way through the range of motion. test we're going to do is the McMurray's test. We're going to be having the patient lying supine. I'm going to bring the patient up into hip flexion, and we're going to be feeling over the joint line to find the medial lateral aspects, to feel for the meniscus. I'm going to be palpating over the posterior medial aspect here, and I'm going to extend the knee and apply an external rotation while also adding a varus force. And then for the lateral meniscus, I'm going to be feeling on the lateral aspect, and I'm going to be extending, internally rotating, and applying a varus force. And we can also combine these and do them all together to see if we can propagate both sides at the same time. And if there's pain while we're testing the medial side or pain in the lateral side, that would be a positive test for a meniscal tear. What we're going to do is the Steinman's test. We're going to have the patient lying supine, and I'm going to bring them up to 90 degrees of knee flexion. I'm going to be feeling over here over the joint line, and while I externally rotate, if they have pain in the opposite side of the knee, that would be a positive sign for a possible meniscal tear. And if I go internally rotate and they have pain on the lateral side, that could also be a positive sign for a lateral meniscal tear. The next test we're going to do is the Thessaly test. We're going to have the patient standing. We're going to have them go ahead and stand on one leg, and on the leg that they're standing on, they can have a slight knee flexion. And we're going to have them rotate from side to side. And if they have any pain or discomfort over the joint line on the medial lateral aspect, that would be a positive test for a possible meniscal tear. For the Ottawa ankle rules, these rules are used to determine if a radiograph is needed. The first rule is the inability to weight bear both immediately after injury or in the emergency room for 4 steps. For rules 2, if there is point tenderness over the distal aspect, so 6 centimeters from the posterior edge of the tibia or the tip of the medial malleolus, and also on the lateral malleolus, over the 5th metatarsal, and over the navicular bone. If they had point tenderness over any of these points or they were unable to complete the 4 steps, they would need to be sent in for an x-ray. So the first test we're going to do is the Mulder's test. We're going to have the patient sitting in a long sit with their foot slightly off the table. We're going to be taking a pencil or pen and be poking in between the metatarsals, in between the joint line here. And what we're trying to do is provocate any of the nerve endings. A positive test would be a reproduction of a symptoms, or if we heard any clicking, that could be a possible sign for a tumor. So the next test we're going to do is the anterior drawer test. We're going to have the patient be sitting with their leg off the table. We're going to be having one hand supporting over the calf, and the other hand we're going to be cupping the calcaneus. We're going to have them in slight plantar flexion. And what we're going to do is apply an anterior force to the ankle joint. A positive test would be if the talus slides anterior from under the ankle, or there may be hypermobility, clunk, clicking, and pain. And that'd be a positive test for a possible tear in the anterior talofibular ligament. And we can also do the anterior or the posterior drawer test. Same positioning and everything, except now we're going to apply a posterior force to the ankle joint. Same indications if there's any pain, hypermobility, clicking, or clunking. And we're going to be testing for a possible tear in the posterior talofibular ligament and capsular ligament. The next test we're going to do is the varus or inversion stress test. We're going to have the patient in a seated position with their leg off the table. We're going to be grasping the lower leg and cupping the calcaneus here. We're going to apply a dorsal flexion to the foot and an inversion force. That will be testing the PTF. Then we'll go to a neutral position and an inversion force to test the CF, and then a plantar flexion position with the inversion to test the ATF. If there's pain in any of these motions or an excessive gapping, that would be a positive test for a sprain in one of those ligaments. For the eversion or valgus stress test, we're going to be testing for the integrity of the deltoid ligament and the tibiocalcaneal ligament. We're going to have the patient be sitting with their leg off the table. We're going to have one hand on the leg, the other hand is going to be cupping the calcaneus and talus. We're going to want to make sure that our thumb is going to be over the deltoid ligament. Then we are going to apply a eversion or valgus force to the ankle. A positive test is if the talus tilts or gaps excessively and there's pain, and this would be an indication of a sprain in the deltoid ligament. And if there's pain at the distal synostosis, this pain may indicate a distal talofibular sprain. The next test we're going to do is the rotation test. We're going to have the patient seated with their leg off the table. We're going to be grasping to stabilize the lower leg, and we're going to be cupping the calcaneus. We're going to apply a rotation force back and forth across the ankle joint to try to provocate any of the ligaments. And if they had a tear in either the medial compartment, that would be a positive test for the deltoid. And if it was on the lateral side, it could either be the ATF, the CF, or the PTF, depending on the location of the pain. For the next test, we're going to be checking for plantar fasciitis. The first thing we're going to do is check for palpations. We're going to be palpating over the bottom of the foot at the insertions and origins of the plantar fasciitis to see if we can provocate any symptoms or cause pain. We're also going to be checking to see if we can find any crepitus or any nodules that are in the fascia. And then the next step we're going to do is... So the second part testing for plantar fasciitis is called the windlass test. We're going to have the patient be standing on a stool with the head of their tarsals just slightly off of the stool. We're going to make sure that they're weight bearing over their testing leg. We are then going to apply toe extension over the big toe. And when we do that, there should be an increase in pain over the entire fascia, or there may be pain over the insertion and origin of the fascia. And that, if that's true, that would be a positive test for plantar fasciitis. For the third part of this test, we can also do the windlass test basically in a seated position with the foot off of the table. And we'll be here, passively apply toe extension. And if we see an increase in pain or pain over the fascia or anything like that, that'd be a positive test for plantar fasciitis. The next test we're going to do is the Kleiger's test, or the external rotation test. We're going to have the patient seated with their leg off the table. The examiner is going to use one hand to stabilize the leg, and the other hand is going to be over the medial aspect of the foot. And the first part of the test, we're going to be have the ankle in dorsal flexion and apply an external rotation to stress the synostosis. Then we're going to put the ankle in slight plantar flexion and apply an external rotation force to stress the deltoid ligament. A positive test is if for the deltoid ligament would be medial joint pain, and for the synostosis there would be pain described in the anterior lateral aspect of the ankle. The next test we're going to do is the heel strike or tap test to determine if there is a fracture. We're going to have the patient in a long sit with their ankle off the table. The examiner is going to apply dorsal flexion for the ankle. The next step is we're going to apply a forceful tap on the calcaneus to send upward. And a positive test is the vibrations will be sent up the long bones of the leg and will cause pain at the site of a possible fracture. The next test we're going to do is the figure 8 test. We're assessing swelling in the ankle joint. We're going to have the patient sitting in a long sit and have them about 20 degrees of plantar flexion. We're going to start the tape over the tibialis anterior tendon. We're going to draw immediately over the navicular tuberosity. Then we're going to go over the proximal arch of the foot, then over the base of the fifth metatarsal, and then we're going to draw it across, back over to the tip of the medial malleolus, to the back around the Achilles tendon, to the tip of the lateral malleolus, and back to the start. And we're going to take that measurement. We're going to take this measurement 3 different times and take the average, and we compare it to the non-injured side. And if there's an increase in the average of measurement, that would be a positive test for swelling in the ankle joint. So the next test we're going to do is the compression distraction test. We're going to have the patient lying supine with their legs slightly off the table in knee extension. We're going to apply a compressive force starting proximally against the lower leg and moving all the way distally. When we're applying the compression force, we're checking for fractures, and while we're applying this compression, it's going to cause a distraction down at the distal end of the long bones, and that would be testing to see if there's any dislocations. And if there's pain over the compression, that would be a positive test for a possible fracture. And if there's pain in the distal end, that could be a positive test for a dislocation.